Okay, thank you, Nakacho. Thank you, Dr. Nakacho. So today we would have discussion on right side heart failure. It's not as such an update, but because it comes in an update lecture, I labeled this update. Not most of the information that I am going to share are new to you. Some of you know it, and I just want to emphasize certain points. So on this talk, we'll emphasize on peculiarities of right side heart failure, especially in comparison to left side heart failure. Okay. So let's first entertain definitions of right side heart failure. If like the left side heart failure, we can simply define right side heart failure when the right system fails to perfuse the lungs or does perfuse the lung with increased central venous pressure. But the International Working Group on Right Side Heart Failure defines right side heart failure as a clinical syndrome arising from impaired ability of the right heart, mainly the right ventricle, to perfuse the lungs at a normal central venous pressure. As you imagine, RV dysfunction in the right side heart failure are not synonymous because the syndrome can also be caused without RV failure, and also some RV dysfunctions are compensated without clinical evidence of increased central venous pressure, so they are not actually synonymous. So before we go to the pathophysiology, it's worthwhile discussing the structure of right ventricle. The right ventricle, morphologically, structurally, and biochemically distinct. When you see the morphology, the normal RV seldom exceeds 2 to 3 centimeters. It's a very thin-walled structure, and this is a very compliant ventricle when compared to the left ventricle. And the mass, as you expect, is 1/6 of the left side, the left ventricle mass. And when you see alpha structurally, the RV has got abundant alpha myosin heavy chains isoform. This is an isoform with more rapid but less efficient energy consuming chain. And so compared to the RV, the myosin heavy chains are that of the RV are alpha ones. Okay. So this is just the pictorial representation in the gross anatomy of the RV. As you can see, the RV is situated hanging or wrapping around the left ventricle, sharing the interventricular septum in a normal. The second panel A shows that the RV wrapped around the LV, and it appears as non-ellipsoid crescent shape. Okay, and compared to the crescent shape, they are the ellipsoid left ventricle. When it dilates, it goes away from the left ventricle and from the free wall side, but the septal side compresses the left ventricle, which we will see in the pathophysiology, the significance of this. Okay, and on section, the RV has got 3 important parts: the iliate part, which is the tricuspid area, and as you know, the tricuspid annulus has got a larger surface area compared to the mitral annulus, and this makes it susceptible to morphologic changes in RV, so that we get more functional TR than MR in any when there is RV pathology, and when compared to LV pathology. And the trabecular part is something which characterizes the LV and with different bands. And the third part is outlet part, is where the RV outflow tract is located. So embryologically, both ventricles originate from different heart fields. The LV, for example, originates from the first heart field, while the RV originates from the second heart field. This makes a distinction in terms of response to loads, and also expression of certain genes during pathology. This is important to note. So that makes it different in why pathophysiologically these two ventricles respond differently. Okay. So this is morphologic and physiologic difference between the RV, and it summarizes the morphologic and physiologic difference. As we've discussed, the mass is the mass of RV, the thickness and the pressure the RV generates are much less than that of the LV, and the maximum E velocity, the resistance, vascular resistance, as you can imagine, this is also is very low, 1/10 of the normal, the left ventricle, and the stroke work index correspondingly are also different. Okay, and when you see adaptation disease, as I discussed previously, RV is a very compliant ventricle with adaptation to volume changes, but it little adapts to pressure changes. But this is the reverse in case of LV. So when you see RV contractility, LV contractility is usually simultaneous, occurs at the same times, and is characterized by torsional and rotational movements. But in case of RV, what happens is the contractility is sequential, starting from the inlet going to trabecular and the outlet. So it appears to be like peristaltic movement. Okay, and the fibers are arranged in such a way that most the fibers are longitudinal from apex to base, and this contributes to 80% of contraction. And radial contraction is limited, accounts for 20% of RV contractility. And there are three separate mechanisms of contraction, which are important to understand the diagnostic tests and also in the treatment of RV. The first contraction area is a RV free wall contraction, an active contraction, and this results in inward movement of the RV free wall. And the longitudinal contraction from apex to base is also a very important one. And traction of free wall from septal wall. This is also important, okay? And with this traction, meaning when a septal wall contracts, it tracks to the free wall of the right ventricle, resulting in shortening of this fiber, inward movement of this fiber, resulting in injection of blood. So this contributes to the LV systolic functions, okay? And longitudinal contraction is usually assessed by TAPSI, which we are going to see it in the diagnostic part. So any test which assesses these three components of RV systolic function is ideal to test RV function, but none exists. So when you see ventricular independence, this is also very important in some pathophysiologic conditions of RV. You know, RV and the LV work in series and in parallel. By series, we mean that LV pumps what the RV gives to it. Okay, so the volume that the RV ejects determines the volume that the LV is going to eject. Okay, by parallel, we mean that these two ventricles contract at the same time, and the contraction and the feeding of one ventricle affects the other one. Okay, for example, in a normal situation, the interventricular septum is convex to the left ventricle, and concave to the left ventricle, and convex to the right ventricle, meaning bulges out into the right ventricle for obvious reasons, because the LV is higher pressure area. And with RV pathologies, especially with volume and pressure overloads, what occurs is this septum goes more to the left ventricle, squishing the left ventricle. Okay. And this will result in abnormal filling of the left ventricle and increased in the diastolic LV pressure, which is responsible for some manifestations of right ventricular pathology. So this interventricular dependence is very important to conceptualize certain RV pathologies. Excessive dilatation of RV impedes LV feeding through their shared septum and excessive volume administration. So this is also important during treatment, like in a patient who has already compromised left ventricular feeding because of volume overload at RV. If you give excess volume, the patient will have worsening of the LV feeding and resulting in progressive hypotension and organ hypoperfusion. So just to see the significance of LV contribution to RV contractility, there was a study done many years ago to show that RV systolic function is driven majorly by LV contractions. So what they did was they electronically separated RV and LV and paced separately these two ventricles, meaning there is no electrical transmission through the myocardial fibers from LV to RV and from LV to RV to LV either. So by doing so, when they paced only LV pressure is generated, as you can see, and RV pressure is also generated with corresponding PA flow, meaning pulmonary artery flow. But when they isolatedly paced the RV, there is no pressure generated in the left ventricle, and there is no flow in the aorta mater. And there was also generation of right ventricular pressure, and there is generation of also PA flow. So from this, what you can imagine is that even if RV is not paced or electronically active, the presence of LV contraction can just drive blood flow from the RV to the pulmonary artery. So there is a significant contribution of LV contractility to RV systolic function, and some estimate to be 50 to 60% of RV contractility is generated by the LV. So with this, you can imagine that any shared septal abnormality has the deleterious effect on RV function. So it's worth to know this. And when you see the normal RV response to increased load, especially after load, we say that the RV is highly sensitive to changes in afterload. Afterload, we mean the impedance to right ventricular flow from the pulmonary circulation. It can be due to pulmonary artery vascular tone, or it can be due to decreased compliance, or it can be due to distributions of pulmonary capillaries and also from the respiratory movement. So this all impedance grouped together are called lumped impedance. It's not only the vascular tone, but this also contributes to the RV afterload. So how does the normal RV response to changing this afterload is better demonstrated with pressure volume loop, as is the case for left ventricular functions. Okay, with changing. So this is a site where there is in the diastolic volume. So there is a little isovolumic contraction and isovolumic relaxation in the patient in RV when compared to LV. There is usually the change in volume. So the isovolumic contraction and relaxation is shorter when compared to LV. So with rising pressure, the patients, the RV starts to eject blood, and this is the distance from here to is the stroke volume. So with changing afterload, as you can see, the RV contraction will also change. So it tries to couple the change in the afterload with changing intrinsic contractility. So this can be known by using the indisystolic point. These are the indisystolic point. Okay. So if you map this indisystolic point and draw a line, you'll get a slope. The slope of this line is called the indisystolic elastance of the RV, and they indicate the RV intrinsic systolic contractility, which is load independence. So the slope does not change. Normally, if you see this angle and this angle will be the same. Okay. So with changing afterload, located in the broken line on the right side. The RV also adapts to it by changing interesting contractility. So the slope of this remains the same. So this is called end-systolic elastance, and this is not load dependent. As we are going to see, the other RV function tests are load dependent, so they can be affected by changing bit-to-bit change of volume or afterload. So, but this one does not change in a normal situation. So when you see the difference in the response to change in the afterload between LV and RV, as you can see, this is mean pressure changes in the outflow of these ventricles, and this is a stroke volume. So the stroke volume rapidly drops as a slight change in the afterload occurs in the right ventricle. Okay, so this shows that very little adaptation to pressure change in the RV. But here in the left ventricle, you can see that it remains flattened. So there is a minimal change in the stroke volume, even if the afterload is increased. Okay, so this is very critical in understanding, especially in acute pressure overload, like from pulmonary embolism or other obstructive conditions. So the difference is quite visible. What is the reason for this difference? So when you see afterload in the systemic circulation, it's the major. There are two things when we discuss about afterload: compliance and resistance. Okay, and the major resistance in the systemic circulation is at the arterial levels, down in the tissues. Okay, and the compliance, meaning holding of blood, is more in the large vessel, okay, so the large vessels can hold large amount of blood without increasing blood, so increasing pressure, and in elderly patients we have enhanced wave reflection, meaning the arterioles reflects some of the pressure that was generated from the LV systolic pressure back to the systemic circulation to the large vessel area. So this results in a notching of pressure curve in the aorta. So this indicates that the vessel compliance is critically important in adapting to pressure change in the left side. What occurs in the right side when you see the pulmonary circulation? One thing, this is a very it occupies a small area in the body with only the pulmonary circulation. And the other thing, when you see the vessel characteristics, the large vessel compliance is only 20% in the pulmonary circulation. So minute pressure change can impact on the RV. And the small vessels are critically responsible for the compliance. That's why blockage of small vessels, like in pulmonary thromboembolism, at least 50%, can result in significant pressure overload on the RV and result in right side heart failure. So this difference is responsible for difference in the response to pressure overload. So what about the preload? As we've discussed previously, the right ventricle is highly adapted to volume change. It's meant to deliver whatever volume it is given to certain limit. The limit is usually the pericardial constraint. So it has got a very large reserve for pumping the higher amount of volume when compared to the LV. So what causes in the case of pressure volume overload, if the RV has got great reserve, what are the causes which can result in RV failure in the presence of RV volume overload? One is distensibility of its free wall. So the free wall distensibility has got a limitation, so it has got a reserve. Because of the pericardial constraint, it is limited, so it can't accommodate to without limit. And the other is the symptoms comes because increased volume overload result in underfilling of the left ventricle because of the shared sector. So in the presence of volume overload, these things result in symptoms. One is the limitation by the pericardial constraint. The other is the squishing of the right ventricle, resulting in underfilling of the right ventricle, results in symptoms. So this is I just discussed. The other contribution for the symptoms which I need to emphasize is the functional tricuspid regurgitation. As I've discussed previously, tricuspid valve has got a very large area of annulus. So any morphology change in the RV beat dilatation can result in functional tricuspid regurgitation, which will contribute to the volume overload. Okay. This is just what I've mentioned. As you can see, the RV is a crescent shaped on short axis view. With bowing into the right ventricle, but with a volume overload, it pushes and the left ventricle will appear like a D, and with flattening and even bowing of the interventricular septums to the RV, to the LV. Okay. So having said so about the pathophysiology and normal response to certain loading conditions. So what are the causes of right side heart failure? So we will focus more on the RV abnormality. The forms of right side heart failure can be classified into acute and chronic. In the acute, usually the pressure overload contributes to the manifestations. And the most common causes of acute RV failure can be classified those which are associated with increased afterload. This include the PE is a very good example, and certain patients like in ventilated patients, if our parameters are not set appropriately, patients can have also RV failure. And others are ARDS and hypoxia, because oxygen is the most important physiologic pulmonary vascular vasodilator. So the hypoxia will have a vasoconstrictive effect and increase afterload. Acidosis does the same thing. So these are causes of acute pressure overload, but there are also causes which result in decreased systolic functions like right ventricular myocardial infarction, myocarditis, and some injuries because of cardiac surgery are also responsible for acute RV failure. When you see volume overload during acute conditions, excessive transfusion and left ventricular acid device sepsis can result in a decreased contractility in the volume overload. Okay, so chronic is vast, and the most common cause of chronic RV failure is left side heart failure, and the others are causes of pulmonary hypertension, which I don't go to it in detail. They can be classified as a precapillary and postcapillary. The precapillary include idiopathic primary pulmonary arterial hypertension. The current term is just primary pulmonary arterial hypertension, congenital heart disease, hypoxic lung injury, chronic thromboembolic conditions, and other miscellaneous causes. So these are causes of chronic right side heart failure. So just few points about acute right side heart failure. The causes are, as I've mentioned, right ventricular infarction, and this is usually associated with inferior wall myocardial infarction, and usually occurs because of dominant right side circulation, and right coronary occlusion can result in right ventricular infarction. And the involvement of the right ventricle has got a very important prognostic value, like during the pre-reperfusion era, if RV occurs, the mortality rises to 30% with inferior wall MI. And occurrence of inferior wall MI and right ventricular wall MI has worse prognosis than large anterior myocardial infarction. Okay, this is even true during this reperfusion era. Okay, so RV dysfunction or RV failure portends poor prognosis in many cardiovascular pathology, and it's more so with right ventricular infarctions. Okay. So, and the other is in acute pulmonary embolism. So patients with acute pulmonary embolism have got RV involvement, and RV dysfunction also increases the odds of worse outcome by 2.6. Okay, so those who have got RV dysfunction has got 2.6 times higher mortality than those who do not have RV dysfunction. Okay, and evaluation of RV function is critical in terms of treatment, like requiring for thrombolysis. Okay, so like in some massive, if they have got little bleeding risk, that this kind of groups are candidates for thrombolytics, and also for massive PI with hypotension. This group or hypotension or bradycardia, this group are candidates for thrombolytics right away. Okay, so evaluation of RV is critical. So the most common case in our setup where we have decompensated chronic pulmonary hypertension, as you've heard in our morning session, two of our patients presented in fact with decompensated RVV. They had actually previous pulmonary hypertension. So this is a usual scenario in our setup as a cause of acute right heart failure. And there are other conditions which are also responsible for acute heart failure, like post-cardiac surgery, transplantation. The patient can have right heart dysfunction. And ARDS, now we are seeing quite a lot of ARDS patients because of COVID. So referral for echocardiography is high. But the most common indication being to rule out pulmonary embolism. But the case is most patients with ARDS, like based on the criteria you use, like 25% can have RV dysfunctions, okay, without P. So ARDS by itself is a cause of RV dysfunction. So the mere presence of RV dysfunction does not indicate that the patient is having pulmonary embolism. So we need to have our clinic. You need to use our clinical judgment and also CT findings to help treatment. Okay, so presence of a right heart failure does not indicate that the patient is having pulmonary embolism in patient with ARDS.
But Dr.
So we have
Dejuma,
discussed about the part. Yes.
You mentioned that
yes,
in the definition of right-sided heart failure, the pulmonary arterial pressure is normal. That's what you said earlier on. So do you include here compensated cor pulmonale? Because in your first slide, when you defined right-sided heart failure, you said pulmonary arterial pressure is normal. Huh?
No. That's about central venous pressure. Shouldn't be. Is that you are referring to, right? Normal central venous pressure.
Okay.
Yeah.
Sorry.
It's not about pulmonary pressure. In fact, pulmonary artery pressure is the most culprit or cause of the right side heart failure. Okay. Did you get my point?
Yeah. Sorry.
So in pathophysiology, we have discussed that afterload increment is very important one. Just before we proceed to the other discussion, just to mention some what are the adaptive changes in increased pressure overload in the RV. The first one is, as you can imagine, is increased in contractility. So the RV hypertrophies. In certain situations, RV hypertrophy can be seen within 48 hours of the insult. Okay, so this occurs because of rearrangement of sarcomers and also dilatation. And in the maladaptive situation or failed states, the RV starts to dilate, and the contractility will decrease, and the patient will have low preload and rise in feeding pressures of both ventricles, and TR will occur, which result in a vicious cycle, increasing volume overload. Okay. So what are the clinical presentations of RV failure? The symptoms and signs come from three main pathophysiologic points. The first is due to venous congestion, systemic venous congestion, and this can be symptoms of body swelling, as edema, hepatic congestions, ascites, and whatever. And signs like increased jugular venous pressure, and also sorry, signs of hepatomegaly and ascites can be detected. Signs and symptoms of concomitant LV failure, especially in the chronic right side heart failure, LV failure symptoms are also found because these are the commonest causes. And also, as we've seen, the LV feeling pressure may be affected. The patient may have some abnormality in that regard, though the LV failure signs and symptoms are not predominant in this situation. When severe and the patient has got acute pressure overload, and patients will have symptoms of decreased LV feeling, like syncope, pre-syncope. That's why we see syncope in pre-syncope in some patients with pulmonary arterial hypertension, especially when there is a concomitant RV dilatation. Okay. So some laboratory abnormalities related to RV failure. One is elevation in biomarkers. With RV damage, like in LV abnormality, we can have raised cardiac biomarkers, brain natriuretic peptide, troponin can be elevated. And this, though their diagnostic use is limited to differentiate RV in LV failure or from other non-cardiac pathologies, they have a good prognostic value, like raised BNP and troponin indicate the patient has worse prognosis, and sometimes they can be used for follow-up of treatment. And patients with long-standing right side heart failure, hepatic congestion, cardiac loss are common. And so later on, we may have findings which suggest the congestive hepatopathy, more predominantly of cholestatic types, but at early stage, patients can have raised transaminases, and they can have also low albumin. And sorry for the interruption. And some patients may come the urea nitrogen with slight rise in creatinine. So the preload, decrement in preload and renal venous congestion in increased systemic venous congestion can be the reason why they have these findings. So in evaluation of patients with suspected RV failure, these are the objectives or the rationale of evaluating such patient. So the first is to demonstrate that the patient is having RV failure. Okay, so we see some tests which are important in that regard. And the second aim is to identify possible underlying or precipitating cause, because addressing this thing may be curative and also in relieving the symptoms, useful in relieving symptoms, and more importantly, in determining prognosis of certain cardiopulmonary pathologies. So presence of RV failure, as I've alluded previously, indicate patients with RV failure have higher mortality and other endpoints. So determining RV function is critical. Okay. So what are the tests for RV function? And there is no such ideal test, especially in the clinical utility. So we will use our clinical judgment and integration of the findings of different tests. So we can classify basically into two, non-invasive and invasive. With regard to non-invasive, echocardiography is the most commonly used and widely available, and critical information can be obtained. And in majority of the cases, we can reach out a specific diagnosis and demonstrate the presence of RV failure. What are the types? Transthoracic with certain limitation, transesophageal, better evaluation of RV morphology and resolutions. And these days 3D echo is very important, especially the TTE, TE 2D ones. They do give less resolution in terms of volume. So volume assessment is better made with 3D and MRI. So strain echo is also very important. Like in in a patient with a global deformation abnormality. Global strain is very, very important. Strain, sound strain ለማለት ነው. And the other one, which is now not that much recommended, is radionuclide imaging to see the volume of RV. But nowadays we're seeded by MRI, okay, or 3D echo. And CT can also be useful, especially if there is other indication. Otherwise, MRI is better. CT, like if we suspect that the patient is acute PE, CT can be used. And the perfusion scanning is better for chronic PTs, but for acute PT, we prefer CT scan. And invasive measurement is a gold standard, and also and also the most important in terms of assessing a response to treatment and or even choosing certain vasoactive treatments. So I think this slide is not that much clear, but anyhow, it's about 2D echo, use of 2D echo, and in a patient with suspected right ventricular abnormality, and it's very inexpensive, and it can be used at any sites. And in better hand, it may have good endocardial definitions with 3D echo. So what of the tests that we do with this imaging or invasive modalities, the determination of RVEF, meaning RV ejection fraction, is the most important, okay? But the problem with this is it's all load dependent, meaning varies from different loading conditions. And in certain imaging like 2D echo, the determination of RV is limited because volume cannot be appropriately assessed with 2D echo. The other is RV. This is just for those who are interested in echo. RV fractional area change. This is also another parameters which you use to assess RV function. It better correlates with RV ejection fraction, and can be measured by using MRI or 3D echo. TAPSE, the well-known and the one which we commonly report, it has got also strong correlation, but at the RV function advances, it has poor correlation. And the problem with TAPSE is TAPSE means tricuspid annular plane systolic excursion. We say that longitudinal motion of the longitudinal fiber motion is one of the major contractions. So TAPSE assesses the longitudinal movement of the tricuspid annulus. So the normal value is greater than 17. So it can somehow show the RV function, especially if the septum is normal. And the other very important one with tissue Doppler is S prime, meaning the displacement by using tissue Doppler, we can assess the S prime. And it has been shown that especially in a patient who is borderline or moderately reduced RV, ejection fraction better correlates, okay? So we use a cut point of 10 centimeter, meaning the displacement of the tricuspid annulus by using tissue Doppler can also be useful for assessing RV functions. As I've discussed, RV strain imaging is also important because this is a global RV assessment. RV strain can be done with 3D echo, with 2D echo, and also MRI. So these are some of the parameters which are used for assessing right ventricular function. What I want to emphasize is that the TAPSE, which you use commonly report, is greatly loading dependent. So we need to take that into consideration. And in MI in the cabbage, it has been shown that the patient with low TAPSE will have very poor prognosis. Okay. And here, which as I've discussed as previously, pressure volume loop is a gold standard in assessing right ventricular function, but it's invasive, cumbersome, not clinically available. So it's just at laboratory based and research based. So, but it is the most ideal one to come to the determination of RV function, and it's load independent. If you use RV elastance, that's the last row, that's the load independent determinant of RV functions. And this is just to show you that RV ejection fraction is one of the prognostic markers in patient with reduced ejection for LV with reduced ejection fraction. Okay, so as in the top panel, you can see with normal pulmonary arterial pressure with preserved RV function, the prognosis is good. But with normal PAP or low RVF or high PAP with preserved RVF, the outcome is in between. And with the group 4, the last one, with high pulmonary arterial pressure and low RVF, the outcome of a patient with left ventricular dysfunction is very much dismal. Okay, so meaning they have got a very poor prognosis. This is just to show that RV ejection fraction has a very good prognostic value in patients with LV dysfunctions. So this is just about tricuspid annular excursion or TAPC. So it just tells you the longitudinal motion of the RV. So what are the other indices like the pulmonary arterial hypertension and myocardial performance index and systolic and diastolic tricuspid anomalies also are important in evaluating patient with RV function. So a lot myriads of RV tests, but the most important is RV ejection fractions. How can you calculate the RV ejection fraction? By using 3D echo or MRI. And what are the reliable indicators of decreased RV function from 2D echo? TAPC is the most important, and tissue Doppler showing decrement in S prime. So this is the way we use. So if you have decreased S prime, decreased TAPC, they may indicate that the patients have poor RV ejection fractions. And other predictors, especially, I just brought this slide to just show in patients with ARDS of different causes, the transpulmonary gradient, TPG means transpulmonary gradient. This is obtained by measuring the mean pulmonary artery using catheters and measuring pulmonary capillary wedge pressure, meaning the surrogate marker of left ventricular filling pressure. So the difference between the two is transpulmonary gradient, meaning the pressure that drives blood flow from the pulmonary artery to the left atrium. So this determines the outcome of patients with ARDS. So if TPG is high, patient will have poor outcomes. So this is the importance of determining TPG, especially in ARDS. So just it shows that as the RV dysfunction worsens, the patient with ARDS have got poor outcomes. So when you come to therapeutic considerations, few slides, we have little times. The goals of treating a patient with RV failure is simple. It encompasses or it has got 3 tenets. The first is to reduce afterload, because that's the one which drives RV failure. And the second aim is to increase RV contractility. And fourth one is optimizing fluid status. Okay, so these are the 3 aims of treating patients with RV failure. So with regard to optimizing fluid status, this is one of the challenges in treating our patients who come with decompensation. So the most guiding principle is using central venous pressure. Ideally, one can use central venous catheter to measure that, but clinical interpretation of this procedure is not demonstrated. So we just use a clinical judgment. And the target is to keep the central venous pressure between 8 to 12. In a patient who has got, especially with low blood pressure and also congested, the initial attempts starting with a very low volume to just expand the
Sorry, doctor, proceed. Dr. Zakios, please mute your mic. Proceed, doctor.
To expand, to increase the LV preload. And the way to know the amount of fluid required is just to follow the blood pressure of the perfusion. So but we shouldn't be aggressive, because increase in RV volume can result in further decrement in LV preload. So we need to pay balance between hypoperfusion and fluid replenishment. Okay, So when we diuresis also, we need to avoid rapid diuresis because the rate of our diuresis shouldn't be more than the way the intravascular volume is replenished from the extravascular side. So if that occurs, the patient will have decreased preload and worsening of hypotension. So we need to keep that balance. So what are the management in refractory cases, like in a patient who's been on diuretics but comes with decompensation? The strategy is first to increase the frequency of administration, to add other diuretics. The value of infusion of diuretics is not that much evidenced, but one can try, especially with isolated right ventricular failure, but frequent doses can do the same thing. And mechanical removal, by using ultrafiltration or dialysis in refractory cases are recommended. In hypotensive, in the congested cases, we still continue to give the diuretics with inotropes. So we don't need to stop the diuretics unless the patient has got a very low blood pressures. So we play between the two. So what are the things that you use for increasing contractility? And we have usually two common inotropes, dobutamine and the milrinone. Dobutamine, for its long use and some evidences, it's more preferred than milrinone, and both increase contractility. And sometimes we may use a combination of both. And some may add also nitric oxide with little evidence also to dilate the pulmonary artery. And in some patients with chronic pulmonary hypertension with RV hypertrophy, phosphodiesterase 5 inhibitors like sildenafil may be used, but as we will see in the next slide, this use is without evidence, and sometimes also it has got a negative, deleterious effect. Okay, so there is no place to use sildenafil or 5 phosphodiesterase inhibitors unless there is vasodilatory response after catheterization. Okay, dopamine in the norepinephrine may also be used with systemic. If there is concomitant systemic hypotension, one can also use dopamine or norepinephrine. So the other goal is to reduce afterload, and this is also important, especially in certain conditions where underlying treatment is possible, like in primary or pulmonary arterial hypertension. With vasoreactivity, one can give vasodilators. Okay, and the other vasodilators which we use for left ventricular failure can also be used just for the purpose that post-capillary pulmonary hypertension can be reduced. Okay, and the routine use of pH-specific pharmacologic therapies in left heart failure cannot be recommended. So we cannot use this pH-specific treatment just for RV failure if there is no concomitant pH. This slide is congested, but just to show you that the negative study with sildenafil in a patient with RV failure if there is no pulmonary arterial hypertension. Okay, and some patients have developed adverse renal outcomes, so sildenafil cannot be used for that purpose. pH-specific treatments, phosphodiesterase, as I've told you, this is just for pH, not for all RV failure. So there are some single-centered studies, and the other group of pH-specific treatment are endothelin receptor antagonists. Can be used like bosentan if there is vasoreactivity. And the other is soluble guanylate cyclase stimulator. This is coming into picture, especially in pH, but this has been shown to improve quality of life in pH, not in all RV failure. And prostacyclin agonists can also be used in pH-specific RV failure. Okay. So this is last slide, which is obtained from 2018 American Heart Association recommendation for right side heart failure. Just a revision of what I have said. One thing which we probably need discussion is arrhythmia management. Some causes of right side heart failure are arrhythmogenic, like arrhythmogenic right ventricular dysfunction, and patients are also having atrial fibrillation. So AV synchrony, meaning maintaining AV synchrony and septal synchrony, especially in those patients who have got septal dyskinesis and they are candidate for CRT, they should be treated improve RV outcomes. And these are my points regards to RV failure. If you have questions, we can entertain. Thank you.
Thank you, Doctor. So we will have the post-case while you are entertaining questions.
Any question?
How commonly do you encounter an isolated right-sided cardiomyopathy? Is it really?
Okay. So it's not common, but like in certain genetic abnormalities, we can have arrhythmogenic right ventricular dysfunctions and some non-compunction syndromes. These are some inherited ones, but isolated right ventricular dysfunction is common in those patients with pre-capillary pulmonary hypertension. Okay, so like in PE, in a patient with good pulmonary hypertension without LV involvement. And in our practice, we do have a higher proportion of isolated RV function because of domestic air pollution related pulmonary hypertension. So we have quite a lot of patients with COPD, interstitial lung disease, or previous pulmonary tuberculosis who come with isolated right-sided heart failure. So it's not uncommon in our practice, and in our spectrum study of 6 universities, it contributes to the 4th or 5th of cardiovascular heart failure in Ethiopia. So it's not uncommon, but as in any other country, a left side heart failure is the most common cause. Any other question?
Can you see the chat box, Doctor?
Sorry?
So there is one question in the chat box.
Okay, let me look at it. Okay. Is there any possible parameter used on echo for the assessment of RV diastolic dysfunction? Yes. I just didn't go in detail of the RV function assessment because it's quite complicated and maybe out of the scope of the audience. But we can do it like using tissue Doppler, the same techniques that we use for LV diastolic function assessment. But tissue Doppler is the most commonly used one to assess diastolic functions. And the problem is that is RV function assessment has a little attention because people thought that RV is just a conduit for volume or volume supply to the left ventricle. So we can do diastolic assessment by using tissue Doppler and or also 2D echo with pulsed Doppler like the LV function studies. And what we need to know is most commonly we find mixed feature, in both systolic and diastolic dysfunction.
Okay.
So shall we proceed to the post test?
Yeah, so it's ongoing. So for the sake of time, I will end it here and I will share you the result. So
Good.
we have 52% response rate. So 53% response rate. So here is the result. Can you see it?
Yeah, I see it. The first question is patient with inferior LV wall and RV wall has worst outcome. Okay, so compared to even to large anterior wall MI. And with the second question, I didn't actually discuss this, but it's good to discuss it now. The characteristic echo finding, what we call the McConnell sign, is apical sparing with mid-free wall hypokinesis. Majority, 79% responded properly. And in the case of RV anatomic and physiologic characterization, 46% say that RV is more sensitive to volume change than pressure change, but this is not correct. 48% respond that close to half of the systolic function is by LV contraction. This is a correct answer, okay? Which of the following RV function test is load independent? I think you have, from the presentation, you have noted that RV elastance is load independent, but it's not clinically available, okay? And in the management of acute right ventricular failure, dobutamine is preferred inotrope, answered in 96% of the respondents. So this is what I have. If you don't have further question, we can end up here. Thank you.
Thank you so much. So have a good day.
Okay.